Hi, everyone. Looks like we have a good portion of the participants today still joining us. I'll give another minute or so and then allow for a couple more people to log on to the meeting. It's 12, let's see what time is it right now. 12:02? Okay. All right, so let's start. And then as people join in, they'll join into the webinar. My name is Dr. Zach. I currently work at Mercer-Bucks Orthopedics. I've been here for over 8 years. I've been practicing podiatry for the past 15 years. And for the past 8 years, I've been here at the Mercer-Bucks Orthopedics and have been treating patients in all of their offices that we are at. So today we're going to be discussing bunions, what bunions are exactly, what causes bunions, and several treatment options that we have for bunions. So let's first start with the anatomy of the great toe joint. Let's begin here. We have a normal looking foot on the left and an abnormal foot, which typically we would see as a bunion. So there are three components to the bunion. There are three bones there. You have the long metatarsal bone. You have the great toe, or the hallux, which is comprised of two bones here. As you see a little bit more on the right, you can kind of start to see more of anatomy of the bunion, and seeing the normal anatomy, you can see exactly kind of what the bunion entails. So what is a definition of a bunion, or the term on the right where you see is HAV, it's called hallux abductive valgus, and that's more of a medical term for exactly what is happening to the great toe joint. So what we typically see when patients come in, or what patients typically see, is you see a large bump on the side of your foot, and most people would think it's just that they have this growth growing on their foot, but what really is happening is their normal anatomy is starting to protrude, and as you can see in the image on the left, your long metatarsal bone, that first metatarsal bone, seems to be sitting further out and protruding through the skin. As you can see, the skin, there's almost a bump along the side of the skin. But that is not the only deformity that's going on there. As you can see to the big toe joint, you can see it shifting closer to the small toe joints. And all that soft tissue that's sitting along the inside part of that joint, where you can see the tendons and the sesamoids and the adductor muscles there, are actually pulling onto the big toe joint, creating a retrograde force back onto the long first metatarsal bone, thus pushing it further over. And as the bunion will progress, as you will see later on in the lecture, you can see the progression of bunions from a mild case to a more severe case. So some of the signs and symptoms of a bunion, as you can see on the right, you would see the redness. You see that protrusion, or that bump that people will say that they have along the outside part of the foot. You'll also see that the great toe starting to shift closer to the smaller toes. But people will primarily describe some swelling, the redness, the bump. Some will develop corns or calluses along the bottom aspect of the foot around the bunion. And primarily, obviously, is pain. Pain is the biggest complaint that we have with the bunions. And the final complaint is limited movement, but those are usually more in the later severe stages of bunions. So some of the causes of bunions. When we talk about the bunion itself is not inherited. It's actually the foot type that's inherited. People who are more predisposed to developing bunions have certain flexibilities in that great toe joint, or the first metatarsal, that predisposes them to develop a bunion. Typically, the foot stresses or injuries are more related to any type of injury that occurs, whether it's ligamentous injuries or previous fractures, that can lead patients to develop a bunion. And then deformity present at birth. Some patients can develop a bunion as early as birth, but typically we don't see them at birth. But there are certain anomalies that do occur, that as the child progresses to adolescence, patients do develop either adolescent bunions or juvenile bunions that does progress to more severe bunions later on in life. So some of the risk factors. When we talk about high heels or ill-fitted shoes, which are tight-fitted shoes, or toe boxes that are too narrow that push and squeeze the toes towards the front of the shoe, it aggravates the bunion per se. So there has to be some type of inherited foot type that predisposes instability of the great toe joint to shift over towards the small toes and thus develop a bunion itself. Rheumatoid arthritis is an inflammatory arthritis. It's not your typical degenerative joint disease osteoarthritis that people get with wear and tear. This usually affects the soft tissue or more the ligamentous in the capsule and the tendons and tissue around the joint that creates instability of the joint, thus developing bunions. And again, hereditary, which is the typical foot type that people are inherited with. So here are some of the stages. On top, you will see what every patient sees, and what patients come in with is a different bunion as it progresses from mild to moderate, large, and severe. And then below, you'll actually see radiographically exactly what happens to the foot that creates that topical appearance of that bunion. For the mild case, again, you can see that the long bone, the first metatarsal, is fairly straight. It's almost parallel to the second metatarsal. There's not much of a deviation of the joint. There's some mild leaning of the great toe joint with a small bump, and that's typically what a mild case would be. In the moderate case, again, you would see that the parallel lines between the first and second metatarsal are widening. The angle is getting larger, and that great toe joint is starting to shift further towards the smaller toes. The space between the first and second toe is starting to get more narrow, and you develop a larger prominence. Once you get to that third stage where you have the larger bunion, the protrusion of the bump is more significant. You have significant deviation of that great toe towards the second toe. You start to get a hammering of the digits. And on the x-ray itself, you can see there's instability and a significant widening between the parallel lines between the first and second with a larger angle. And the great toe joint itself appears dislocated, where that big toe joint is sitting almost on the inside part of the first metatarsal, and those are two little small bones that you see are shadows, are sesamoids. You can see they look like they're almost completely displaced. And then the final stage, where you have severe arthritis, you have a very large, what's called an intermetatarsal angle, which is what we were talking about, the parallel lines between the first and second that is significantly large. You have an overlapping second and third toe, where the second and third toe are literally sitting on the big toe joint, and you have a large bunion. So let's discuss some of the different treatment options that you can implement to help slow the progression down, maybe help with some of the symptoms of the bunion itself. Again, we begin with some bunion pads or bunion straps. When you're in the first or second stage, early stage, you can pad it and you can strap it. And that would help alleviate some of the signs and symptoms, or the swelling or the pain. Maybe help slow the progression of the bunion, as well as the orthotics. All these treatment options will not completely stop the progression of the bunion, but it will slow the progression of the bunion. Wider shoes as well. Again, all of these are just preventing any type of external force on the big toe from shifting towards the smaller toes. The injections and the NSAIDs are more to treat localized pain or swelling or inflammation, especially around the great toe joint itself. So next, the topic we discussed is surgical treatment options. And again, we treat these based on stages, primarily not only stages of the bunion itself, but also what we're dealing on from a radiographic standpoint. So when patients will come in for consultation, not only do we evaluate the topical appearance of the bunion itself, but as well as radiographic weight-bearing x-rays to really give us an appreciation of what and how disabled or dislocated the joint is, and how much instability you have in between the first and second metatarsal, so that we can determine what is the best surgical option for you. So from the first stage, where you have a mild, as you recall from the previous x-ray, a small bump. If patients are having just bump pain without any angular deformities, what we do is called a bumpectomy, which really we would just take the bump off. I haven't performed that procedure in a very long time, because most patients aren't coming in with a mild case. They're more moderate to severe or large bunions. Most of the procedures that we perform are usually in the second or third stage, which is a more mild, moderate to severe. With the moderate to severe, depending on the intermetatarsal angle, which again is the angle between the first and second metatarsal, you can perform what's called an MIS, which is a minimally invasive bunionectomy, where you can perform a bunion and a correction of the bunion with 2 or 3 small incisions. There's the distal metatarsal osteotomy, which is something where we have to cut the bone a little further closer to the joint, again, not needing to correct that much of the angle, and some greater toe joint osteotomies. Stage 3, which is more of a larger bunion, there's usually an inherent instability and flexibility of that first great toe joint and the first metatarsal, where we can correct it distally or do MIS or minimal invasive procedures. We have to approach them a little more aggressively with either a proximal osteotomy, which is a cutting the bone a little closer to the midfoot area or the larger bone of your foot, as well as what's called a lapis arthrodesis, which is fusing the joint that is hypermobile or unstable to correct the bunion itself. So here are some images of what exactly a bumpectomy is on stage 1, which is a mild case again, where you can see the gray shaded area on the left. That's exactly what you're doing. You're just taking off the bump just to give some patients some relief because they really don't have any angular deformity on the radiographs. Our stage 2, I wanted to just show you a comparison. You might not be able to see for the picture on the right where you have 2 small little slits. That is considered MIS bunionectomy, where you can correct the bunion, which is a moderate bunion with those 2 small incisions, versus an incision that's on the left, which is more for a moderate distal osteotomy, and as well as a great toe joint osteotomy where you have to put some type of fixation. Both those procedures are done same-day surgery. Both those procedures allow the patient to walk in a walking boot immediately. Both those procedures do require some type of screw fixation. The difference between the two is, again, as you can tell, is the scar size, as well as pain and stiffness and range of motion. With the procedure on the left with the large incision, patients do experience a little bit more stiffness in the great toe joint after surgery, since we do have to open up the joint, versus the procedure on the right, which is the MIS bunion. We're not exposing any joint surface. We're not exposing any joints. It's done with small incisions with precision tools where we can correct the bunion. Patients will have very limited stiffness in the joint with limited pain and return to full activity faster than with the larger incision. The stage 3 procedure here, as you can tell, we have some radiographs. Again, that is a larger incision. It's very similar to the incision that we previously talked about, but these are a little more advanced bunions where there's a severe instability and inherent larger bunions in that foot, and that's why we have to do some more work to correct that bunion. And with the screws that we're placing in there, and as well as the large incision, so that we can approach and expose that joint to fix it. So the final stage, obviously, that's the more severe case where you have the arthritis, you have the stiffness, you have the very large bunion that we showed with the overlapping of the second and third toe and the hammering digits. Those procedures, once they get that dislocated, we can't correct it with any osteotomies. We typically would have to fuse the joint. On occasion, if there is still inherent instability of the great toe joint, as well as an increase in IM angle, we have to do a combination of doing a procedure where there on the left where you have the toe fusion, as well as some proximal osteotomies. And then again, we talked about overlapping hammer toe correction. And again, these are the severe cases. So when patients come in, again, when they come in with any type of bunion pain, any type of issues about bunions, my primary and first question always is how much pain you're having and how often are you having it, the level of pain you have. Because in the end, indication for surgery is always going to be pain, especially for bunions. Cosmetically, we wouldn't recommend having the procedure done unless there is some pain component to it. Since if there is no pain and you do undergo the surgery, there is always inherent some stiffness, maybe some soreness in the region. And I would not recommend having surgery done on an area where there is no pain, where potentially you might have some residual pain after procedure, versus an area where you have severe amount of pain. And when we do the correction, we decrease the pain level severe enough that you maybe have a little soreness. So that is more of a successful type of procedure versus having something where there is no pain and subsequently you develop some soreness. So at this point now, if you have any questions, you can either submit it through the Q&A or through the chat. There's also a website here on the side that you can submit some questions that we can further discuss anything that you have or any questions you have about bunions. Any questions? So the question here is, at what point should I come in if I think I have bunions? It's always beneficial to come in and have the bunions evaluated. But again, primarily, if you're having pain and discomfort and you notice that you're starting to get the redness and your bunion's starting to cause you discomfort, I think that's when you should come in for an evaluation. So the question again is I patient asked if they have very large bunions and they have no pain. Again, I don't recommend any surgery. If you have no pain whatsoever with bunions, I wouldn't recommend the surgery. Again, like I said, if you have no pain and you have surgery and you have large bunion surgery, and you end up undergoing the surgery and we do correct the bunion and you don't have the prominence and you don't have the appearance of the bunion, there is a potential for having some soreness in that region or even mild pain, where it can be 1 out of 10 pain. That wouldn't be a successful procedure for you. If you're having 6 to 7 out of 10 pain and we perform the procedure, we alleviate the bunion and we correct the bunion and we alleviate your pain to get down to 1 out of 10, then that would be more a successful procedure for you. That's why, again, I don't recommend having any type of bunion procedure for a painless bunion. Recovery times for severe cases where we are doing the Lapidus arthrodesis, you're looking anywhere from 4 to 6 weeks non-weight bearing, followed by protective weight bearing and a walking boot and physical therapy to follow as well. So typical recovery also varies depending on the type of bunion procedure you have. For a more moderate to severe case versus a large bunion, for a moderate procedure where you're doing either MIS bunionectomy or what's called a distal osteotomy, you're looking at about 4 weeks in a walking boot, followed by physical therapy. For this, again, for the severe cases, you're looking at more 4 to 6 weeks non-weight bearing, followed by protective weight bearing and physical therapy to follow anywhere from 2 to 3 months. So if you have other conditions with the bunion itself, it doesn't complicate the repair. So if a question was asked is, if I have a Morton's toe and a bunion, does that complicate the surgery? It wouldn't, because the Morton's toe is actually a type of a hammer toe that can be addressed at the same time as you're getting the bunion correction. So the question again is prevention of bunions. Again, once you have a bunion, you can't prevent the bunion, but you definitely can slow the progression. And it can vary depending on how severe a case you have. Can also depend on how the progression. If you're already a severe to a large or even a moderate case, the progression is already slowly getting there. You can pad them off with either bunion pads or bunion straps, wear wider shoes, wider toe boxes, even go half a size bigger in shoe. Orthotics, if you have a foot type that's inherently predisposing to develop a bunion, orthotics can help slow the progression by changing the mechanics of the joint, but it's not going to fully stop it. It just can prolong the progression of it. Now, again, if you have a bunion and you don't have any pain, all these conservative options are great for you, because it just really will slow the progression of the bunion and you won't have any pain, and you might even help the appearance of it. So if you're starting developing hammer toe and you're starting developing the bunion without any pain, I do recommend getting some type of either hammer toe spacer, or a strap, getting a bunion shield to take the pressure off of those regions, especially if it's your second hammer toe and your bunion, as well as wearing the orthotics. So the other question is, if toes are starting to cross, are there things that can help? Depending on how severe the crossover of the toes is, if it's flexible, if it's rigid, if they're able to be reduced, meaning that if clinically we're able to move the toes around, or if they're very stiff, there's different things they can do. There's different spacers that you can try. If it's earlier on, usually when we deal with somebody who's adolescent or teenage, in the early stages of crossing over toes, you could put toe spacers in. There's different devices that you can purchase to kind of get the toes to help straighten them out. But as time progresses and they become a fixed deformity, those toe spacers, all they do is actually just space them out. They're not going to help slow the progression or help with the toes. They're just going to pad them off so you're not having any irritation. And that should kind of answer the next question. Do you recommend any toe spacers? Again, if I do recommend toe spacers from a conservative standpoint, if you would like to try some toe spacers, definitely to help with the hammer toes and the bunions, and if they are providing you relief. But again, you would definitely have to get something a little bit wider of a shoe just to accommodate the toe spacers. So regarding the orthotics, yes, we do orthotics. We do basic kind of over-the-counter orthotics, as well as custom mold orthotics if you do need them. We will provide those services for patients as well when they come in for an evaluation. And yes, we do see patients in Pennsylvania. I myself am in Langhorne at the St. Mary's location there at the St. Clair building. We're there every other Tuesday afternoon. My associate there is there every week. She's there, I believe, twice a week every week, and I'm there every other Tuesday. So here are some other questions. What age for young people do you recommend for bunion surgery, or is it more for conservative care? For bunion surgery, I wouldn't recommend anything younger than 16 years old, just because of growth plates. Now that age can vary, because some people, female patients, usually their growth plates solidify at a younger age versus male patients. So it all depends on what the x-rays show us, depending on how young we would do a procedure. But like typically, I recommend anywhere between 16 to 17, nothing younger than that. Fixing it earlier will stop the progression. It all depends on the level of bunion and what type of procedure you have done. If we are going to be dealing with more juvenile bunions, we typically address those a little more aggressively than somebody who's anywhere between their 30s and 50s. If you have to do a moderate procedure, just because they have a higher potential for recurrence, so we try to approach them more aggressively and to prevent any type of recurrence. Recovery time for a moderate bunion, typically it's about 4 weeks in the walking boot. And regarding driving, it all depends on obviously if it's your right foot, you wouldn't be able to drive for that month. But if it is your left foot, you're able to drive, as long as obviously you're wearing a device on your left foot and it's not a manual. And there's another question regarding recovery time. Again, that's regarding a moderate to severe. More moderate cases, you're looking at walking in the walking boot for 4 weeks versus a more severe case where you're non-wavering 4 to 6 weeks. So somebody asked if you have hammer toe pain, but no bunion, and the pain is not relieved by a toe spacer, what are your options? If they're not relieved by a toe spacer and you get no relief with wearing wider shoes or bigger shoes, then there's the surgical option, again, depending on the type of hammer toe you have. If it's flexible, non-flexible, you would either have to have some tendon release, you might have to have an arthroplasty, which you're cutting out some of the joint, and possibly even either internal or external pin fixation, with recovery depending on internal or external pin fixation for 4 weeks in a walking boot versus a post-op shoe. So if you'd like to set up an appointment, you can call our office, as well as there might be a website you can go on to. But if you'd like to call the office, it's 609-896-0444. I am typically at all locations, including the Lawrenceville office, the Princeton office, Hamilton office, and the St. Mary's office, which is in Langhorne, which I'm there every other Tuesday. So this patient here is asking if their upper joint of the second toe closest to the tip is positioned towards the first toe. That's usually caused by some type of deformity in the toe. It could be an anomaly of the way the toe grew. It can also be trauma to the growth plate. You may be younger if you had some type of injury to the toe and the toe grew towards the toe. If it's painful and discomforting, that can be fixed. Again, it would have to require some type of surgical boning correction and possibly pinning. So if somebody's asking me a question about a ganglionic cyst versus a bunion. Ganglionic cysts are more of a soft tissue cyst. It's a mass. It's a benign soft tissue mass. Typically, it's filled with synovial type fluid. It usually occurs over tendinous areas, either on the top of the foot, around the ankle. Most people will see them around the wrist, but it can occur around the foot and the ankle. It's due to irritation. Very rarely is it sitting on the bunion itself, unless there was some type of trauma to the capsule itself. But usually it will be sitting on top of the bunion if you do have a ganglionic cyst present. They can be treated both conservatively and surgically. From a conservative standpoint, you would have to aspirate the cyst and then inject it with some steroid to kind of calm the cyst down. But if you continue to have discomfort and pain in those regions, and they do have a high recurrence rate if the cyst is still present, then they would have to be surgically excised, as well as make sure you take out the cyst and the cyst sac itself, as well as the stem from where the fluid is filling the sac in, to prevent it from recurring. So somebody asked if joint replacement surgery for osteoarthritis in the big toe part of an option for bunions or something separate. It can be part of the option of a bunion depending on how severe the arthritis is in the joint. Typically, what type of joint replacement you do with an osteotomy, where you do a typical bunion procedure, you would do a hemi-arthroplasty of the great toe joint, and you put a hemi implant that's titanium to preserve some of the joint. Total joints I typically don't do, where there's celastic implants. They have a higher recurrence rate, higher redo rate. The joint, and it gets destroyed by the plastic, and it's degenerating the joint even more, and then you have to do more aggressive surgery, or requires bone grafting. So typically I don't do a celastic type total joint replacement. more of a hemiarthroplasty. We do have hours in Hamilton. Someone asked that question. I'm in Hamilton every Monday morning, Wednesday afternoon, and every other Thursday morning, sometimes into the afternoon. And I do see patients in Hamilton typically one Saturday a month, and it varies on the month. So somebody asked a question where they have a bunion, they have a hammer toe, and they're actually having hammer toe pain, not as much as bunion pain, and they're actually having constant pain and swelling on the ball of their foot. That can not only just be a hammer toe and where you're having issues just with hammer toe, but you can also have sustained what's called a plantar plate tear. What that is that there is a thickening of the capsule on the bottom of the second toe that holds the toe down. If there's any disruption of it, it can create a hammer toe deformity, and thus you're having that pain on the bottom of the foot. That is typically assessed either clinically or you would have to get an MRI to really see if there's a plantar plate tear. If it needs to be repaired, you address both the hammer toe as well as the plantar plate by fixing the plantar plate during the same time as you fixing the hammer toe. So the question asks if we would do both feet at the same time if we had bunions. I actually never recommend having both feet done at the same time. It's actually going to be, it would be very uncomfortable, it would be very painful. It would be very hard for you to even getting around. Even if you're in a walking boot for about 4 weeks, you'd still be very uncomfortable getting around, and plus the pain itself. I wouldn't recommend it. And again, I wouldn't perform both feet at the same time. You're creating surgical bone cuts in both feet and having to screw just like a fracture. Again, it would be very uncomfortable to have fractures in both feet, let alone choosing to have that. I would definitely not recommend. So somebody asked if somebody has a severe case of bunions and immobile second toe, do we prefer to do the surgery at a hospital and outpatient? I prefer to perform most of these outpatient procedures at an outpatient facility like a surgery center versus a hospital, but that also depends on patient's age as well as any comorbidities that patient have, any past medical history that requires us to have it done at a hospital. If some patients prefer to have it done in the hospital, we would perform it at the hospital. So somebody asked if there's any physical therapy that can be done to correct hammer toes. Again, depending on how severe they are and how dislocated they are, how rigid they are. There's certain toe curling exercises they can do. You can probably go online. We might have some stuff on our website where you can go into physical therapy for toes. But if you type in physical therapy for toes or hammer toes, there's different types of exercises they can do to help with the toe itself. I don't think it will definitely correct a hammering digit, but it can help with some of the stability of some of the other toes and help slow the progression of them. So somebody asked that if they had surgery done earlier on, that it didn't hurt much earlier, would it prevent bigger surgery later on? Again, it all depends on how severe the bunion is. If you have a moderate case and you perform a moderate procedure, but there's some inherent instability of the bunion, there is a potential for recurrence. When we talk about bunion surgery, there's a potential for recurrence 10 years, depending on what type of foot type you have. If you have something that's a moderate bunion, you don't have that inherent instability, then sure, you probably wouldn't need to have surgery later on down the road. And we always strive to make sure that whatever procedure that we select for you and that we both agree upon, that we don't have that higher chance of recurrence or a higher chance of a need for further surgery. We always want to make sure that whatever we do right the first time, so that you won't need to have a secondary surgery. Again, if you have any other questions or concerns, there's a website here that you can log on to and you can send it towards us. There's also, might be getting some more information emailed to you. Then if you have any further questions, you can contact us at any time. And if you feel that you want to come in for a consultation, please give us a call. We'll get you in as soon as possible. We are, again, I'm in pretty much in all the locations, and we can see you in any of those locations. Thank you for joining me today at this webinar regarding bunions. Hopefully this was informative for you. And again, contact us at any time. Thank you.